Hello, thank you for joining this webinar. My name is Stephen Broderick from Johns Hopkins, and it's my pleasure to discuss the development of the Pulmonary Resection Composite for the General Thoracic Surgery Database. I have two disclosures listed here which are not related to this work. The STS General Thoracic Surgery Database has previously developed composite quality measures for both pulmonary lobectomy and esophagectomy for lung cancer and esophageal cancer, respectively. These composite scores and the corresponding star ratings are included in the General Thoracic Surgery Database semi-annual participant feedback reports, and they are available for public reporting. In addition, the GTSD has developed risk-adjusted models for morbidity and mortality after the more broadly defined lung cancer resection, including in the model additional extensive resections such as wedge resection, segmentectomy, bilobectomy, or pneumonectomy. The aforementioned measures have adjusted for surgical approach, minimally invasive versus thoracotomy, in the risk adjustment models. The aim of the Pulmonary Resection Composite project was to develop a quality composite measure that would include all pulmonary resections performed for lung cancer. Two main reasons to undertake this initiative were first, that there have recently been an increasing frequency of sublobar resections performed for early stage cancers, namely wedge resections or segmentectomies. These procedures are not captured in the lobectomy composite and thus are not included in risk-adjusted feedback programs. Second, an overall pulmonary resection composite provides a broader measure of program performance in lung cancer surgery. The development of the measure was similar to that of the lobectomy and esophagectomy composite scores. The General Thoracic Surgery Database was queried for all pulmonary resections for lung cancer between January of 2015 and December of 2017. Composite scores were calculated as a weighted sum of risk-adjusted or operative mortality and major morbidity. Major morbidity was defined a priori, consistent with the morbidities included in the pulmonary resection composite. Individual participant rates were then estimated using a Bayesian hierarchical model, and assignment of performance categories or star ratings were made according to the methodology used in the prior STS measures. This slide shows the extent of resection for all cases included in the model. There were 38,461 pulmonary resections included. The majority of cases were lobectomies at 70.7%. 15% of cases were wedge resections, 7% segmentectomy, 1% sleeve resections, 3% bilobectomies, and approximately 3% pneumonectomy. Pathologic stage was predominantly stage 1 at 68%. 19% of cases were stage 2, 11% stage 3, and 1.6% of pulmonary resections were performed for patients with stage 4 disease. This slide demonstrates the overall percent and participant median for the main outcomes, including operative mortality with an overall percent of 1.29% and the major morbidity composite of 7.9%. The components of the major morbidity composite are listed, including return to the operating room, pneumonia, initial ventilatory support over 48 hours, respiratory failure, tracheostomy, ARDS, pulmonary embolus, bronchopleural fistula, and myocardial infarction. The most common major morbidity was pneumonia at 3.6%, followed by respiratory failure and return to the operating room. The composite scores and associated confidence intervals are shown graphically here, with the composite score plotted on the y-axis. The horizontal dashed line represents the mean composite score. Those programs for whom the composite score is below the mean and the confidence interval does not overlap with the mean are shown in red. These programs are one-star programs or performed worse than expected. Those programs whose composite score lies above the mean without overlap of the confidence interval are shown in blue. These are 3-star programs. The remaining programs, shown in black, are 2-star programs, namely those for whom the confidence interval of the composite score overlaps with the mean composite score. In order to maintain stability of the model, only programs with 30 or more pulmonary resections for cancer were included in the model. This resulted in 214 participating programs. Overall operative mortality was 1.3%, and major morbidity occurred in 7.9% of resections. The majority of programs, 194, achieved a 2-star rating. A 2-star rating indicates that the program performed as expected. That is to say, the program's performance is not statistically different from the performance of the average program participating in the database. 7 programs received performance worse than expected, and 13 programs performed better than expected. Mortality in these 3-star programs was 0.3%, with a 3.6% rate of major morbidity. As part of the development of this measure, we also analyzed the proportion of procedures performed using minimally invasive techniques. Overall, 70.5% of the pulmonary resections included in the model were accomplished using a minimally invasive approach. Previous composite measures included surgical approach in the risk adjustment model. As part of this composite measure development, analyses were performed both with and without minimally invasive approach included as a covariate in the risk adjustment model. It's notable that there were minimal differences between the two models, including or excluding minimally invasive approach. Finally, we analyzed the number of lymph nodes evaluated at the time of pulmonary resection. Pathologic evaluation of hilar and mediastinal lymph nodes is a critical component of pulmonary resection for lung cancer. Lymph node evaluation provides important prognostic information and allows for the identification of patients who may benefit from additional treatment after surgery. The median number of lymph nodes evaluated amongst pulmonary resections performed in the General Thoracic Database was 10, with the mean number of nodes being 11.9. In conclusion, participants in the STS General Thoracic Surgery Database performed the spectrum of lung cancer resections with low morbidity and mortality. The median number of lymph nodes evaluated suggests that participants are meeting contemporary staging standards. There's a wide variety of the application of minimally invasive techniques among participants, and risk adjustment for minimally invasive approach in the composite model resulted in only modest overall changes to star ratings. Thank you again for viewing this webinar. The webinar slides and other materials will be posted on the STS website. Please direct any questions or comments to Sydney Clinton, STS Senior Coordinator, Quality Metrics and Initiatives at sclinton@sts.org. Thank you.